Dear colleagues, welcome to the new and today's episode of the Masterclass in Clinical Trials. I'm happy to host this session together with Aisha Kader. And Aisha, who is a fellow student in the Master's Program in Clinical Trials at the University of Oxford. Dear Aisha, thank you for your time. Thank you for organizing this. And would you like to introduce our guest today?
Yes, please. Thank you very much, Jared. It's my absolute pleasure to introduce Dr. David Hildick-Smith, who is a professor of interventional cardiology and a consultant cardiologist at the Brighton and Sussex University Hospitals NHS Trust in the UK. He is a pioneer of clinical trials in coronary bifurcation stenting and is the PI of the EBC MAIN trial presented at EuroPCR last year with publication in the European Heart Journal. He has also led the British Bifurcation Coronary Study, or BBC, as well as the EBC2 trial. And with over 20 years of experience, he is an international expert in interventional and structural cardiology, and especially clinical trials in this space, and has published extensively, particularly in the design and conduct of coronary bifurcation trials. Dr. Hildick-Smith is on the scientific committee of the European Bifurcation Club and holds active leadership roles within the BCIS, that is the British Cardiovascular Intervention Society, and the European Association of Percutaneous Coronary Interventions, or EPCI. The results of the EBC MAIN trial have been extensively discussed and dissected over the last year. But today we will hear from Dr. Hildick-Smith about designing trials in bifurcation stenting, with particularly insights from EBC MAIN. Over to you, Professor Hildick-Smith.
Okay, thank you very much, Aisha. That was a very glowing testimony. I'm not sure I deserved it. And I see that you picked a photograph of me that was from at least 15 years ago. So people are looking and saying, that's not the guy that's supposed to be talking. It is actually me. It's just that was a little while ago. So let me share my screen. I'm going to talk for a bit about clinical trials and designing those trials and how they're best done, at least from my perspective, and then we'll open it up for a broader discussion. Do stop me at any stage if you can't hear well or there are any concerns. So I'm going to talk about coronary bifurcation stenting trials, in particular with insights from EBC MAIN, but also from BBC One, which was the first of the bifurcation trials that I sort of set up and ran. So for me, with clinical trials, it's really all about being pragmatic and having the stamina to see through something that you initially think is a good idea and worth pursuing. Because it will inevitably be disconcerting along the way as you come across hurdles and obstacles and difficulties, but you have to have the determination to continue. What you're looking to do is select a really clear question with a potentially clear answer that will be of clinical relevance, that will be manageable in a realistic time frame, and the design of which will be aimed to complete in a reasonable amount of time and actually give you a very clear answer. Now, I don't know who it is who said this. Rod Stables used to say this, and I like it. Everyone wants their trial to be good, quick, and cheap. But actually, unfortunately, you can only have two. Because you can imagine how your trial could be good and quick, but then it's going to be expensive. It could be good and cheap, but it's going to take a long time. Or perhaps worst of all, it could be quick and cheap, and it'll be rubbish. So it's actually worth bearing these three factors in mind. You can't really have everything that you want. Now, some years ago, Peter Glennon, my colleague who's in Coventry, and I sat down at TCT when there was some hurricane or something. It wasn't the most terrible thing, but it was a hurricane. And we sat down for a whole morning and basically designed BBC One and a version of EBC MAIN. And that was in about 2002. So this trial, the BBC One trial, was a trial of provisional versus systematic dual stenting in non-left main coronary bifurcations. You'll recognize a consistent theme here. And it was published in the end in Circulation in 2011, but it was envisaged in 2004. So, you know, the amount of time you have to dedicate to taking something from first concept to completion is really a long time. It's a great deal of energy that has to be involved in making sure that this idea comes to fruition. So I looked back on my computer to find the first document about BBC One, and it was actually this. So this was the logo. So obviously started with the most important.
Could I just interrupt you for a second? Could you put it on full screen because your slides aren't moving? We're stuck on the first slide.
Oh. How can that be? I got it on full screen and
I stopped the sharing, and then now we can restart the sharing.
Try again. Yes. Let me try it again.
Perfect.
Oh, I don't know why it didn't work. It was on full screen. So anyway, I apologize. I'll keep going and get to the point. Yes. So I look back on my computer, and the first document I have is 2004. And in fact, it's this one. So that was the logo for the study. So obviously started in the most important place of all. I got my daughter to draw a television. So that became the logo for BBC One. Very sophisticated, very high quality. And in some respects, you know, envisaging the study is the exciting part. You think of the question, you think, oh, this is going to be really good. Will people participate? To be a really good study. We'll be able to answer this question that everyone's always deliberating. And so in some respects, if you were being negative, you'd say that's the best bit of your study, is envisaging it, asking the question mentally. And if you were being unkind, you'd say it's downhill from there. It's not downhill from there, but it's a lot of work. So the thing I would suggest, let's say you have an idea for a study and you think, oh, this could be a really good study. I want to do the study. First thing to do is to discuss it with a few valued colleagues, just the notion. And many times I've asked others, or others have asked me and said, oh, I've got this idea of a national study. It's going to go like this. What do you think? And quickly you'll be able to say, oh, I don't think that's very practical, or, oh, yes, that's a really good idea. Definitely, you should do it. So you get an instant feedback from a few colleagues who think, okay, I value their opinion. I want to know what they think of this. And then you can respond as appropriate to their feedback. So there's no point starting some very fanciful Walter Mitty type approach to a study if it's actually not going to work, not going to be practical. So if you are encouraged from the first few conversations you have, then you move to the next point, and that is, does your study pass the sort of first 6 or 7 criteria for requiring a good study outcome? So the first one is, what is the actual question? Is it clear? I'll come back to that. Second is, who are the patients actually going to be? Will sites be interested in the study? Will they recruit? Will there be any ethical issues? How will the statistics go? What specific endpoints are you going to ask? How are you going to fund the study? How are you going to arrange the governance of the study? And these are the really key aspects to any study when you start imagining it. Is your study going to pass these tests? So, for example, the question, I hate 2x2 factorial design stuff that's impossible to understand. If I can't understand it, when I read the abstract, if I don't know what's going on, as far as I'm concerned, that was a useless study. It needs to be a single question, a simple question, not complicated designs. Too often people try and answer more than one question with their study. The premise of the study should be readily encapsulated in a single sentence. If you have to spend half an hour explaining to people why your study is important, why it's good, and why it's clinically relevant, you're failing. So it has to be important enough for the answer to be interesting and clinically relevant. Because remember, in the end, the actual question you've asked and the answer you get to it is the single most important aspect of your study. So the endpoints are really, really crucial. Composite endpoints are quite popular, but they're not necessarily good, and they're often used because people want to make the statistics work. So, for example, a composite of death on the one hand and hematoma on the other hand, that's a terrible composite because one is far, far more important than the other. And actually, you probably think that's a silly example, but we have lots of studies where you have death and a troponin blip of 15 in a composite endpoint. So it's commonly used as a mechanism to make the statistics work, which I'll come on to again in a minute. So of course, composite endpoints should, where possible, carry comparable weight individually. If you choose to have a single non-composite endpoint, let's say you have revascularization, then that has to be often enough of an occurrence to make it possible and plausible to do the study. So, for example, in the PFO closure studies, stroke was going to be the endpoint, and of course that was only going to occur in 1 or 2% of patients per year, and therefore very, very large numbers of patients were required in those studies. Now, there are many studies like that where you can't get around the fact that the important clinical question you're trying to answer requires you to have a composite endpoint which occurs only infrequently. But if there's an alternative way of doing the study that gets around it, then that's well worth considering when the endpoint frequency is as low as that. So thinking of all those requirements that you need for your study, are the patients few or many? Not much point designing a fancy study with all the bells and whistles that you might want if actually the patients that you're going to study are rare. If each center only will see one of these specific type of patients every month, you're going to really struggle. So you have to work out the patients have to be frequent enough to make the study possible. Will the patients actually understand the study? You know, you have to sell it to patients. They have to want to participate. That means it has to be something that can be readily understood, ideally. And then the happiness to consent. This is a really crucial question. Of course, if you're comparing two simple things like stent A and stent B, it's really straightforward. The patient doesn't mind. They're having the stent. Doesn't much matter to them. But if you're contrasting or hoping to contrast two completely separate treatment modalities, for example, bypass surgery versus stent, that's really hard. Of course, it's been done a few times successfully, but you have to take your moment in history spot on to be able to recruit to that kind of study. For example, left main stent versus surgery when left main stenting wasn't routine. So you have to pick your moment perfectly. Then in terms of the sites, okay, what's your plan? You're just going to do a local study? Are you going to do national studies? Are they going to be international? They all have their pros and cons, but crucially, sites need to want to participate. So you need to ask colleagues in other centers. No point starting a study where 3 of you are really interested in the study in your own center, doing a sham controlled CTO procedure, but everybody else in the world says, you can't do that. So you have to ask other people whether things are going to be sensible and manageable. Will it generally be easy or difficult for sites to recruit? And one of the key aspects of that is how disruptive is your study protocol or plan for usual practice. For example, we took part in a study a few years ago where it was a good study, but it required patients coming in with an anterior MI to have extensive cooling through the venous apparatus and quite a lot of paraphernalia and fussing around when they came in. And so after we'd done 2 or 3 of these patients, our enthusiasm for the whole process started to wane, because it was actually very disruptive in a busy lab to have to spend ages doing the study protocol. And that kind of thing is very, very important, because people will slowly drift away from the study if it's difficult to do. It disrupts their daily routines much. Ethics, by and large, the ethics committees are really, really good and will allow a lot of latitude. But you have to think, are there some obvious ethical banana skins? For example, are you asking too much of the patients in terms of radiation dose? Are you asking for repeat invasive tests, which may not be warranted outside the study protocol itself? So these things, again, may fail a practicality test. Statistics is one of my personal bugbears. I think we've allowed ourselves to have the cart lead the horse here. Somebody made statistics king a few years ago. I don't know who it was. I don't like them. And now we have to do everything to be statistically important, statistically meaningful. I think we've got it completely wrong. Statistics are important, but they're not over important. They shouldn't be the driving factor. Studies should aim to be clinically important rather than statistically significant. So, for example, if the statistics suggest you need 8,000 patients per arm in your study, you're going to really struggle. How are you going to do that study? It's going to be impossible. So I think practical statistics is a much better way to go. And I say this in all seriousness, and I know people will laugh and howl with derision, but I think there is some sense in saying, okay, well, what is actually a realistic number of patients that we can recruit in this study? And we did this for EBC MAIN. We looked and we thought, well, these aren't that common. We're going to have 30 or 40 sites. That's what we can afford. We're going to, okay, it's going to be around 500. And actually, that was a practical number, which meant that, okay, we slightly had to massage the statistical aspects to be satisfactory for that. But actually, there's an important point to be made here, because if you do a study of 500 patients and you show no clinical difference between 2 groups, or you show a significant, a clinically meaningful difference between 2 technical approaches, that will be an important finding, because you'll know that fundamentally this means there's actually very little to choose between them. And that's clinically really important. We've got bogged down in statistics because particularly drug companies looking to sell their products use the fact that this is a significant statistic study to sell their products. That's fine. That's, their business. We mustn't get hoodwinked by that. If it doesn't make a clinical difference to patients, particularly in a technical trial, then we don't want to pay too much significance to the statistical aspects. We've allowed ourselves to be led a little bit too far down the statistical route, in my view. I will stop going on about statistics now. Funding is very important. Nobody can do a study without funding. And so it's always worth thinking, well, who's the person to whom the answer to this study matters? Hopefully, if you're lucky, there'll be a medical company that could offer some funding for it. Alternatively, a funding body like the British Heart Foundation. Now, in the case of EBC MAIN, we were quite lucky, and we used the fact that Medtronic had recently made a larger stent, a 4.5 and 5 millimeter diameter stent, which was designed for extra large vessels, of which, of course, the left main is one, and therefore I used that to approach Martin Rothman and others at TCT one year, I can't remember which year, and try and sell them the idea. It's going to cost them some money, but they could see that there was potentially a comeback for them that made it worthwhile. it's very hard, if you don't get any funding, because nobody can do anything without some of the funding being covered. Governance of studies is another tricky area, because governance is very expensive, but it offers the study cachet. If you have a clinical research organization doing your study, that means you'll have a data and safety monitoring board, a clinical events committee, electronic CRF, website, statistical support, etc. This is really good, and it means that when you come to publish your study, it has all the attributes that will indicate that this was a quality study. It had proper oversight, proper monitoring, etc., etc. But it's expensive, so you have to think about that. By this stage, you will have got to the protocol, and a short version is very helpful for selling the idea of the study. The full version is harder, and lots of people actually interestingly fall down at the level of writing the full protocol, because they find writing doesn't come easily to lots of people, and they find it a bit daunting, the prospect of actually writing the full protocol. But just borrow a template from somebody, grit your teeth, fill in all the gaps, and you'll find it's actually not as hard as it sounds. So again, I come back to the issue of stamina. EBC MAIN is published in the European Heart Journal in 2021, and the first document I have on the study was 2011. So this is a decade-long project. And so you have to be determined, you have to just keep going, be prepared to keep going to get the study done. So let's say now you've done a lot of the groundwork, you've got your patients, your sites, your ethics, funding, statistics, governance, you've got your protocol. What are some of the practicalities of the actual study methodology? You mustn't expect your patients to do too much. It's a really common problem with writing studies, particularly company-run studies, that they don't really think about the patient very much. I don't mean that rudely, I just mean they design it and think, okay, another CT scan. Every month, let's get a CT scan. So no, that's not very sensible. You're not going to get ethical approval for it, and the patients are not going to like it, and they're going to get radiated a lot. Don't do that. So keep the visits lean, tailor them very specifically to your endpoints. If there isn't an endpoint at 3 months, don't have a visit at 3 months. It's just extra work for nothing. And avoid expensive tests that are not part of routine follow-up, because these will end up costing a lot of money. Many studies are designed quite badly with multiple visits, multiple extra tests, sometimes extra invasive tests. And these tend to work quite badly because ethics don't like it. They are expensive. And actually, most commonly of all, the patients vote with their feet and decide, I'm not having another TOE. I've had 2 already, and I definitely didn't like the second one. So they will just decide I'm not coming back for the third one. And maybe the third one was the really important one in your study. So the practicalities of designing the study are really important as well in terms of design, methods, endpoint. The ECRF is a area where there can be a lot of mission creep. There's a huge temptation when you're writing the ECRF to ask more and more questions in the fanciful idea or belief that you're going to have sub-studies and interesting additional questions to answer, etc., etc. But actually, the more data you require of people, the less willing they are to participate, both as patients and research nurses, research data officers putting in the information, etc. So keep the data set lean. If there isn't an endpoint about stent delivery, then don't ask questions about it. You only want to record what pertains specifically to your study endpoints. So now you've got all the data, it's all going, it's all started. Actually, this is still only the start in a way, because you have to drive your study. Nobody else really cares about it. You've done the ethics submission, you've done the patient information sheet, you've cajoled the sites, maybe you need an investigator meeting, you'll need newsletters on recruitment, etc. So it keeps being something that needs to be fed to make it work, make it happen. Interest from other people tends to peak early and then drop off. So you have to cajole them to keep recruiting. It's all about the numbers. Without the numbers, you have no study. So there's lots more things to say about the later stages of trials, but I think, this is probably enough. I've set the scene around a trial, how you set it up, how it goes through the early stages, which are the difficult ones. The completion stages start to consider taking care of themselves. So let me stop there and hand back to Aisha to open up for any questions or thoughts.
Fabulous. Thank you. I really like how you make it so practical and pragmatic, because I did read EBC MAIN as well as DK Crash and saw quite stark differences between the two. And my questions were actually formulated to address them, but perhaps some of them get thrown out of the window. I don't know, based on what you've just said about how we should be minimizing things that are perhaps not necessary. But a bit about the nitty-gritties of the trial design, perhaps. So most of these trials are open labeled. I do understand the necessity, of course, that the operator cannot be blinded, but what about the patient? Why is it that the patient needs to know whether they've been randomized to 1 or 2 stents?
I think they don't need to know, but I think we felt that there wasn't any value, particularly to the patient themselves, in not knowing. I mean, all they're going to do is report their symptoms. They were usually not so interested that they had a personal bias, thinking, I hope I get randomized to 2 stents. We didn't have any sense that they would be more likely to report symptoms if they'd had one treatment or the other. I suppose that's the part, as opposed to sort of sham controlled trials, where of course if people know they haven't had the treatment, then they're kind of unhappy and more likely to come back saying, no, I still got a terrible migraine, or whatever it is.
Yeah, no, that makes sense. And I'm also going to revisit the perennial IVUS question. I've heard about why it was not mandated by protocol. I assume it's to make it pragmatic, but have you considered doing the, yes.
Yeah, actually, I mean, to answer your final question there, yes, we're going to analyze it by IVUS, but of course it wasn't randomized by IVUS. And actually, that was a disappointment to me. I really wanted it to be randomized. Slightly goes against my intention to have a really clean study that answers only a single question, but I thought it was an opportunity. And as it happened, some countries, and this is part of the issue with having international studies, in some countries they said, well, we can't do IVUS, you'll have to pay for it because it's not reimbursed. And so that was going to be a problem. Some countries, people said, well, we always do IVUS in these cases, so we're not going to not do IVUS. And some countries said, well, we never do IVUS. So after we tried for a while to get around some of these problems, it became clear that actually it was impractical. So we just decided, well, we will just record whether people had IVUS or not, or ECT, and we will do an analysis of that, which is currently underway, actually.
Fantastic.
I have one question regarding this point. When did you realize that there's a heterogeneity in using IVUS? So was it when you were rolling out, or at what point of time did you realize that?
Yeah, so I'd written the protocol and we were going out to investigator meetings to try to get people to buy in to the idea of doing the study. And we came up against quite a lot of resistance, for different reasons and in different directions. So it became clear to me that it just was not going to be a practical thing to demand IVUS randomization, because it was going to really limit our capabilities to get the patients into the study.
And would you now, if you would set up a new trial, which would include maybe IVUS or another procedure, for example, would you do it another way? Would you ask investigators or potential investigators at an earlier point of time, or do you think to have a protocol which should be debated later on is the right way to go to?
I think it's okay. I think so long as, in this case, it was a kind of subsidiary part of the study. So it wasn't the very key question. If your very key question is being debated in the investigators meeting, then that's not very good, because suddenly you may find you have no study at all. But as it was a subsidiary thing, I just sort of put it in the protocol thinking, you know, let's hope everybody agrees to this. And it turned out in the end they didn't, which was a shame, actually. I think it would have been really, really interesting to see the outcome from that.
Thank you. Back to you.
Thank you. Yeah, I guess that was what I was, the direction I was heading in with the IVUS question. So thanks, Jawed. The next issue is about endpoint and choice of endpoints. So we have bifurcation stenting trials that have cardiac death as part of the composite, and the majority of your trials have had just plain death as part of the composite. So
again, that's a very practical point, because it's really difficult to know. You're only guessing. Most people, their death is not characterized in such a way as to be really clear cut as to whether it's cardiac death or just death. People guess, and may say, okay, well, she died at home after X, Y, and Z, so it's probably a cardiac death. There's just too much uncertainty around actually attributing the death to one thing or another. So we felt it was more sensible simply to go with dead or alive.
That sounds pragmatic, but what about then peri-procedural MI? It's not the conventional universal definition of MI definition that you used. You used SCAI, so that's a significantly higher times of the troponin.
We cheated slightly, because I just think the universal definition's got it all really tied up in knots. With really high sensitive troponins, you had the danger that a tiny little troponin blip was being put in a compartment alongside death and revascularization. They're just not the same. So we were happy to see the SCAI definition with the 70 times troponin, because we felt that otherwise many procedures that were otherwise straightforward would be given a hard time because there was a very small troponin leak, and that actually that might bias against the procedure with more instrumentation. So I think it was a fair decision to try to make the aspects of the composite endpoint slightly more aligned.
Okay. And about the practical aspects of choosing the patients and enrolling them, and at which point are they randomized? And do you have a QCA before randomization, or is it were procedures done ad hoc?
In EBC MAIN?
Yes,
in EBC MAIN?
EBC MAIN.
Oh, yeah. So this was an interesting point, because a lot of European centers in particular did very little diagnostic angiography. So I mean, it would be to continue. Yes. And so we had to find a way to allow them to have ethical approval, if it was appropriate, to be able to put the patient in. Now the way the protocol was written was that, if I remember correctly, you had to have 50% or greater left mainstem stenosis angiographically, plus either clear-cut ischemia, acute coronary syndrome, positive exercise test, positive nuclear scan, positive MRI, etc. And that on those basis, you could go into the study. So again, it was designed in a fairly sort of clinically practical way to allow people to put the patient into the study based on their assessment of what the patient needed in the context of their symptoms. So we didn't want to be too prescriptive and say, for example, you must do an FFR, because that again would have really limited the number of patients going in. And you hope that the vast majority of patients were having the right decision made by experienced cardiologists. Of course, it's not always the case, but we didn't want to mandate specific tests, again, for reasons of practicality and loss of patient recruitment.
Yes, I guess that makes sense. And at which point did you randomize the patient? It was on the table, or
because
I would assume there were different
Yeah.
arms. I mean, there might have been ad hoc. There might have been, as you said, patients who did diagnostics and then
So in the end, we didn't rule against people randomizing ad hoc if that was their standard practice. If you see what I mean, the majority of the cases were not ad hoc, but some centers were very much. We want to carry straight on. Can we do that? And we, as the sponsors, if you like, the study said, well, look, if that's okay with your ethics committee and that's how you normally do it, then, and you have a mechanism of doing that. Some of them would consent the patients up front. Some countries will consent the patients up front for, you're here in a university teaching hospital, there's a bunch of studies going on. If we think you're really suitable for one, we might want to put you in it. Is that okay? Which is very kind of enlightened, if you like, on one hand, and allowed some centers to recruit in an ad hoc manner like that. But that was a minority.
I see. And I'm assuming later on, everyone had a QCA analysis at the core lab, irrespective, after the decision was based on the operator. Is that correct?
Yeah. I mean, there was QCA analysis done, but it sort of wasn't a key aspect of the study, if you like, because we wanted it to be very much a clinically based study. But yes, no doubt the occasional case on QCA analysis probably failed, the strict criteria.
But you analyze ITT anyways, I suppose.
Yeah.
And a very basic question, could you highlight again why you chose to have a core lab in the trial?
Yes, I think it was partly serendipity that Circ, who were the CRO, had access to a core lab, and some of the operators who were in the study worked with Circ and thought, okay, let's take this opportunity to use our core lab and have a look at all the angiograms from that point of view. So it wasn't a key part of the study. I think core lab analysis is, in some respects, overrated for value. It's very expensive. It wasn't in this case because it was being done, as it were, for free. But in general, core lab analysis is very expensive and may not add much over what the clinical site has declared. It adds a sort of verisimilitude or governance stamp, but it's probably very expensive for what you get.
We're talking about expenses when you listed potential funding sources. The first funding source was medical companies, and second was other funding bodies. Was it? I think of two reasons. One is it's maybe easier to get money from a company than from a public funding body, and the second is, did it play a role that when you're working with an industry partner, there might be another expertise joining into your project?
Yes, I mean, they tend to give unrestricted loans. So in other words, they tend not to get clinically involved in it. I think in general, yes, if you can interest a device company in funding your study in that manner, then that's a lot easier than persuading a funding body to give money. And traditionally, funding bodies haven't given that much money to interventional cardiology because they perceive that there's a company interested who might easily give the funds. So yeah, I think in interventional cardiology, always having a good relationship with the companies to interest them in studies. They won't always be interested, but if they are, they have the wherewithal to fund the investigator-initiated study.
And how experienced do you have to be to approach a medical company to sell your idea?
Yeah, I don't think you have to be that experienced. I mean, I wasn't experienced really when I went with BBC One, and that was to Boston. And I think you just have to be, I mean, it helps if you're reasonably confident, but also persuasive and determined. And so I don't think you need to be, if the idea is a good one, you don't have to have a pedigree. Otherwise, how can you ever start? I mean, we had a fellow not long ago who went without any pedigree, particularly went and had an idea about how to introduce a new methodology into flow dynamic assessment in the coronaries and managed to get a study funded. So I think they're generally open to good ideas without you having to have already had a background. It may help if you're supported by somebody who has a background, but it's not absolutely necessary.
Could you give us a bullet point context of what stage of your career you were in when you started with this trial?
Yeah, so BBC One, which was that was I got to be a consultant in 2002, and so I started it in 2004. Yeah, so it was reasonably early, and it took quite a long time in the gestation. But it was just that this was a relevant question that was always being debated in the interventional meetings. So it seemed like a sensible idea. Well, why don't we try and do a trial? And I think it's never too early to start having ideas about a nice randomized trial.
Yeah, that's true. It's probably not too early about the idea, but in terms of experience, when you plan strategy trials like this, it's also a matter of how experienced the operators are. And we have quite robust data, particularly for left main, that the operator expertise has to be of a certain degree. So how did you ensure this? Because for example, in DK Crush, I think the steering committee got them to review their DK Crush cases, etc. So how did you practically approach this with so many centers and ensure that?
Yeah, that's right. That's what they said in their paper. Yeah, 305 reviewed. Again, we took a slightly more practical view, which was that we asked experienced centers with people that were well known, had often been seen in live cases, who had a good reputation. I think we made a nod to quantitative mechanics by saying, okay, you have to do 150 cases a year, you have to do 20 left main a year, or something like, I can't remember the exact details actually, but it was less restrictive or proscriptive than the Chinese studies, and probably the European operators do fewer cases, I think, than the Chinese operators. So it was, just a slightly different emphasis, but relying on relevant expertise. And I must say, I sort of felt slightly ambivalent about it, because on the one hand, I thought, well, yes, it's important that people should be experienced, but on the other hand, it's not very practical if every trial you'll say, yes, here are the results, and everybody thinks, all right, well, I'll go and do that now. You go, well, yeah, but hang on, you don't do 300 of these a year. So I wanted the results to be, broadly applicable, and not just in a rarefied atmosphere of, oh, well, Thierry Lefebvre can do it like this, and Yves Louvard can do it like this, but I don't know about the rest of you. I think we wanted it to be quite, broadly applicable.
Correct, and I guess that makes it more generalizable to everyone.
Exactly.
As well. I wonder really, it's at what point did you conceive EBC MAIN? Because, for example, the two left main trials, they have very starkly contrasting philosophies, if you will, to use the word that you've often used for these, because you had a superiority design where the hypothesis was that provisional was better, and DK Crush had a design where the hypothesis was where DK Crush was better than provisional. So did any of it factor in your decision making as to how to approach, or were these two trials that were run parallelly?
No, well, actually, I mean, it's a good question. Some of it was run parallel because it was 2011 when we started designing EBC MAIN, and we talked about it for a couple of years before we got to the point where we thought we could actually get a sponsor really interested. And so during that time, obviously, DK Crush 5 was kind of happening. And we sort of knew a bit about it, but not a great deal. And so I think, yes, philosophically, we had to approach it the way we approached it, because all our previous studies, BBC 1, Nordic 1, Nordic 3, even Nordic 4, EBC 2, they'd all really shown at the very least that there wasn't a systematic advantage for having a dedicated dual stent strategy. So all of them were in favor of a provisional strategy or neutral. Therefore, really, we had to construct it like that. And actually, we believed very much that the provisional strategy would be more advantageous in the left main because of the bigger angles involved, the greater muscle mass, the greater degree of calcification and fibrosis, the less likelihood of, for example, culotte taking the angle and behaving very well, the greater likelihood of ostial circumflex stenosis, etc. So, yeah, I think we were approaching it in a very different manner.
I suppose a technical question about mandating a KISS in the provisional. Based on Nordic 3, and I mean, there isn't, I would assume in my limited knowledge, data to support kissing in a provisional, if I'm not mistaken.
Yes. So the reason we had that in there was because all of these were true bifurcations. So they all had a 50% plus lesion at the osteo and the circumflex, let's say, assuming the left LAD was treated as the main. So rather than leave it to operator discretion, we thought it's fair, especially given the fact that although in Nordic 3 there was no advantage to kissing, there was actually no systematic disadvantage to it. There was no penalty, as it were. We thought, well, it's only fair if they got a 50% lesion and it's the circumflex, it's a proper vessel, it's not a side branch, we should mandate the kissing, because that it would be quite extreme in a way to have a single stent crossover type approach versus dual stenting without there being KISS. So again, it was to get some homogeneity in the data set so that everything was the same and people weren't leaving 90% ostial circumflex lesions without doing a KISS, because that would have disadvantaged the provisional arm.
No, that makes sense. So do you think these two subsets, for example, in Asia, and essentially the patient subset and the lesion subsets were quite different between DK Crush and EBC MAIN? For example, EBC MAIN had a cutoff of a syntax of less than 22, and some proponents of DK Crush might say that having a cutoff of greater than 2.75, because say if a side branch is smaller, that might be more favorable to DK Crush, that EBC MAIN was setting itself up to have more culotte stenting than others. What are your thoughts on that?
Yeah, I mean, it was highly likely to have more culotte simply because it was run in Europe through European centres who'd mostly been part of the European Bifurcation Club philosophy. So DK Crush was something which the European Bifurcation Club has never really embraced that much, not because it's constitutionally opposed to that per se, but because what the club philosophy has been is that you don't prejudge your outcome. You start, you prepare the vessel, you put the stent in, you do a pot, you do a KISS. If you can stop at that point, you stop. If you need to go on, you go on and you put in a T-stent or a culotte or whatever. Whereas, of course, DK Crush is a technique where you've predetermined, okay, right at the outset, I'm going to put 2 stents in here. And so that's kind of against the EBC philosophy, which is 2 stents is fine, but if you don't need 2 stents, don't put the second stent in. So it was very much a different philosophy, born of a different approach to bifurcations, which starts very much with well, I'm going to start with 1. If I need 2, that's fine. But if I don't need 2, it'll end up with 1.
Correct. I guess my next question was about the angina index. I think there was an angina medication scoring system. I found that interesting because it was just 5 medications. And was that sort of like the PROM? And how important do you think PROMs are in interventional trials, which they're not very known for?
Yeah, no, you're right. Actually, I'm very pleased you picked that up. I popped it into EBC2, I think. Was it EBC2? Oh, BBC1, yeah. And had it again because I wanted to say, okay, fine, we've got those kind of safety endpoints of troponin and revascularization and death and stuff, but actually, how are the patients? Was their angina better? Because that's the majority of reason for doing interventions. I wanted to know, just in case there happened to be a big disadvantage in the provisional group, for example, that turned out, it's fine, but 70% of them have got angina again at 1 year versus dual stent, or vice versa. So I just thought it was sensible. We created that index ourselves. It's got no provenance, it's got no pedigree, it's nobody's sort of tested it against anything, but it just seemed like a sensible thing to do. And actually it was quite useful in BBC One. We could see that despite, and it was published, I think, in Jack something or other many years ago, just saying, here's the health status of these patients according to the technology and or the technique, and it was interesting to see that actually all the patients did well as far as control of angina was concerned.
And it's interesting because I would assume it's just those 5 medications that you asked, no extra questions, nothing else, not a very wide questionnaire.
In BBC One, we had a Seattle Health questionnaire, and we did ask slightly greater depth questions, but because they all came out neutral, we didn't do that as well in EBC MAIN.
Yeah. Okay. And am I not mistaken in assuming that when you have these questionnaires, they have to be validated? So when you invent a questionnaire, as you have done, and it's a very practical one, what's the sequence of how does it follow on? I mean, you showed that it worked in one trial, and so
the sequence is you just keep your head down and hope that nobody notices. And then if you're lucky, people say, oh yeah, no, that was used in the EBC MAIN trial, so that's okay, you can use that.
Yeah, I'm sure we'll be using.
Somebody started somewhere, so it's okay.
Yeah, no, that's a great thought. I wondered, do you have any more slides, or do we continue with the discussion?
No, I thought, because I didn't really know exactly how you would want it to run exactly. So I thought, well, I won't just keep going on and on.
This is absolutely the way
perfect.
This is absolutely the way we hope for.
Okay,
yes,
great.
It's perfect. It's exactly what we had in mind, because it's mainly a practical discussion of the things that you encounter in planning and running the trial. And when you think of interpreting it also, because I think a lot of people mistakenly interpret, the fact that it's a superiority trial and you found no difference. There were lots of misconceptions in terms of the interpretation through no fault of the trialist, of course, immediately after EBC MAIN, where they were saying that provisional is better. So did you?
So I think so. So from that point of view, again, I think this is us as cardiologists allowing ourselves to be fooled by statistical speak. We don't know anything about statistics, really, most of us. And this idea that, it was designed as superiority, therefore X, or, it was designed as, non-inferiority, therefore Y. I think it's a little bit silly. I think you should just look at the results and say, well, okay, there wasn't a big difference between the groups. Okay, numerically, there was some more revascularization in the ones that had 2 stents. Well, okay, let's see if that's the same at 3 years or more. You know, you can use your own brain to interpret these trials. You don't have to be told what the interpretation must be by the statistician. That's my view.
I particularly like that because I don't like statistics much, mainly because I'm not very good at it either.
Well, none of us
but,
are. It's none of us are. There's a huge amount of emperor's new clothes about the statistics you hear people talk about. And you think, I bet if we were all asked, very few of us would pass a statistics test.
That's right. Coming to that point then, how important is the statistician's role in designing the trial?
Yes.
I liked how you worked it backwards, but what did the statistician have to say about it?
Yeah, no, it's very cheeky and you mustn't tell anyone. But no, the statistician, I don't think the statistician is really helpful, but at the end of the study, not at the start. So you have to decide how you run your study, how you design it, how practical it's going to be. But at the end, they're hugely helpful in just chomping through the data and giving you the figures. Because somebody has to do that. And if there's hundreds and hundreds of patients, you need to know, okay, how many had an MI, how many had a revascularization, blah, blah, blah. And the statistician will chew through all the data to do that. And that's really helpful because, again, otherwise somebody else has to do it and you may not yourself be very confident in getting that right. And that has to be done right. So they're really helpful, but I think mostly at the end of the study.
Fabulous. One more question about the DSMB. How did you get about choosing them?
Yeah, so they have to be not participating in the study. They have ideally to have some experience of being a trialist or running or designing or participating in some trials. They have to be ideally kind of neutral to the concept of the study. And then most importantly, they have to be available and willing, because it's just extra work for people, really. So you ask a few people, some say they're too busy, some say, okay, that's fine. Yes, I'm interested in this question. I'll sit on the DSMB.
You're muted.
Yes, apologies. I think we're exactly on the hour, and this has been a very, very interesting and insightful discussion. So thank you very much for your time and also serving us exactly what we asked for, actually.
Great. No, I'm very pleased. And thank you very much for inviting me.
Thank you very much for taking your time.
Yes. Thank you. Bye-bye now.
Thank you.
Bye-bye.
Thank you, Aisha.